Good afternoon. On behalf of the NIH Office of Disease Prevention, it is my pleasure to welcome all of you to today's event from our Prevention in Focus webinar series. This is our fourth webinar of 2024, and we are very excited about today's presentation. My name is Valerie Robinson, a Health Science Policy Analyst here at ODP, and I will be serving as the host for this session. As a background for those joining us for the first time, the Prevention in Focus webinar series was first launched in 2021. The series was intentionally conceived for the purpose of providing a space to hear directly from prevention research experts and thought leaders whose work is driving impactful advances in the spaces of prevention research and public health. Today, we are delighted to have Dr. Wade Self from the Washington University School of Medicine in St. Louis deliver a presentation titled Emerging Evidence for Strategies to Prevent Alzheimer's Disease. Next slide, please. So before we begin, I do want to go over some logistics for today's session. As attendees joined the Zoom today, audio lines, they were muted. These lines will stay muted throughout the session, but please note that this webinar will be recorded and the archive recording will be posted to ODP's Prevention in Focus website, as well as our YouTube channel in the coming weeks. There will be a question and answer session at the end of the presentation. And as stated on this slide, please feel free to submit any questions you have to the chat pod and direct them to hosts and panelists. Also, at any point in time, you may use the chat pod for general commentary, questions to the speaker, or to request technical assistance. We do have an amazing team of ODP staff who are closely monitoring the chat and working hard to ensure appropriate engagement with our speaker today. Next slide, please. So with that, I know we're eager to hear today's presentation. I'd like to thank you all again for registering for this event. And at this time, I'd like to introduce Dr. Marcel Salive, who will then introduce our speaker for today's webinar. Dr. Marcel Salive is a medical officer in the Division of Geriatrics and Clinical Gerontology at the National Institute on Aging here at the NIH. He developed and oversees an innovative research program on multiple chronic conditions in older adults, including national consortia, pragmatic clinical trials, and clinical research projects. Dr. Salive developed NIA's program to conduct research into improving the effectiveness of treatment strategies for the comorbid conditions that occur frequently in combination with Alzheimer's disease. He is a member of the NIH Common Fund-supported Healthcare Systems Research Collaboratory and the program officer for several of its trials. Dr. Salive is also board certified in preventive medicine and a fellow of the American College of Preventive Medicine. Welcome, Dr. Salive.
Thanks, Valerie. It's my pleasure to be here today and to represent the National Institute on Aging, or NIA. For 50 years, the Institute has led a broad scientific research effort to understand the nature of aging and to extend the healthy, active years of life. And NIA is also the primary federal agency supporting and conducting Alzheimer's disease and related dementias research. It's my pleasure to introduce Dr. Wade Self, who's our guest speaker today. Dr. Self is an instructor in the Department of Neurology at the Washington University School of Medicine in St. Louis. He's spent the past decade working with research teams in academia and industry to translate the understanding of the basic neurobiology of disease into disease-modifying treatment strategies for ALS and Alzheimer's disease. Wade's current work aims to understand mechanisms outside the central nervous system that modify neuroimmune interactions in models of Alzheimer's disease-associated pathologies to discover new therapeutic targets and to test innovative approaches for Alzheimer's disease and prevention, treatment and prevention. Outside of the lab, Dr. Self is passionate in working collaboratively within the Alzheimer's disease scientific community to help build trust between researchers and members of the local communities. When he was at the University of Chicago, Dr. Self helped to organize community-based efforts to make Hyde Park a dementia-friendly neighborhood in collaboration with the Dementia Friendly America initiative. He has also served on the executive boards for the nutrition, metabolism, and dementia, and the immunity and neurodegeneration professional interest areas within the Alzheimer's Association, International Society to Advance Alzheimer's Research and Treatment. Dr. Self is committed to living in a world without neurodegenerative diseases. We appreciate the opportunity to hear from him and then discuss his vision on this webinar. Take it away, Dr. Self.
Thank you, Dr. Saliv. And it's really my pleasure and an honor to be here today to talk to you about this topic that's very near and dear to me. And I know webinars, people are the experts that are, working on some of these interventions related to public health. But today I'm kind of serving as a messenger for the field, in that I want to show you and talk to you about emerging evidence that suggests that we may eventually move towards a world where we can prevent dementia and prevent dementia due to its most common contributor, Alzheimer's disease. So to start, I want to make sure we're all on the same page in terms of the terms that are going to be used throughout this presentation. So dementia is essentially an umbrella term that signifies loss of memory and other thinking abilities severe enough to interfere with daily life. So many of us are aware of Alzheimer's disease, and in the United States and globally, Alzheimer's disease is the most common form of dementia, but there are other forms of dementia, examples being Lewy body dementia, vascular dementia, frontal temporal dementia, dementia associated with other neurodegenerative diseases like Parkinson's disease or Huntington's disease. Or mixed dementias in which there are possibly more than one cause that are leading to this loss of memory and other thinking that interferes with daily life. But my hope is that through describing progress made in understanding Alzheimer's disease etiology and combating that pathogenesis with therapeutic or non-pharmacological interventions, that will possibly serve as a framework for understanding other dementia states. And one of the reasons why we think that may be a rational framework to think about is because of the similarities that are observed in many different types of dementia. So in looking at an individual, particularly post-mortem, what we see is this cause of dementia is primarily due to the selective vulnerability and loss of neurons in the brain regions that result in the manifestation of dementia symptoms. So for example, in Alzheimer's disease, at the end stage, you see severe brain atrophy and loss of neurons. But at the beginning, when there's the association with loss of memory, you see those areas such as the hippocampus in the brain that are the first areas that are prone to degeneration that lead to those cognitive symptoms in individuals. And this other then common characteristic in these regions that experience damage and neuronal loss is the accumulation of proteins, either within neurons or extracellularly, that are insoluble aggregates, predominantly composed of one protein, but they're usually a mix of other different proteins. And in Alzheimer's disease, those hallmark pathologies demonstrated here by multiple staining techniques are the accumulation of extracellular amyloid beta plaques and the presence of intracellular neurofibrillary tangles. Amyloid beta is the predominant protein component of neuritic plaques, and hyperphosphorylated tau protein is the predominant component of neurofibrillary tangles. And these pathological hallmarks were even first described by Alois Alzheimer in 1907 in the first case study that looked into the brain postmortem of an individual that experienced cognitive decline and dementia, and then was given the name Alzheimer's disease based on these two hallmark pathologies. So why we are so concerned about this question of Alzheimer's disease and prevent dementia and hopefully preventing this disorder because of its acute effect already in our aging population in the United States and the increase in the age of individuals globally throughout the lifespan. And in 2022, statistics from the Alzheimer's Association say over 6 million individuals are impacted by Alzheimer's disease-related dementia. And that results in a substantial cost to our healthcare system. And these analyses are just thinking about healthcare towards those participants. That doesn't include other analysis that demonstrate that this is a disease that doesn't just impact that person that is experiencing cognitive decline and dementia, but there are costs associated with unpaid caregiving by family and other friends during this steady decline. And that is something that I experienced firsthand, seeing my grandfather succumb to Alzheimer's disease-related dementia, and then also observing how my grandmother, who was that primary caregiver for so long, experienced a similar stress and burden that ultimately resulted in her passing actually a year after my grandfather died. And I don't have empirical evidence, but it's hard not to see how that stress in somebody that is aging into their 70s and 80s could eventually take a toll on them as well. And we want to address this problem and think about preventative strategies because we do not want this disease to cause further stress to our economic and healthcare systems. Because even if it's just that increase in aging of our populations, these projections that there could be in the United States over 13 million people and possibly $1 trillion in healthcare costs associated with care and management of Alzheimer's disease. But we see these numbers, and I think this is an example of data which suggests that prevention may be possible. And there are caveats to these sorts of analyses. Many of them, in terms of dementia research, come from high-income countries, predominantly Caucasian cohorts. But what is interesting to observe, for example, in an analysis looking at multiple cohort studies in the United States and Europe, suggests by decade, the incidence of dementia is possibly going down in these populations. And by their estimates, it was approximately around 13% by decade. So in these solid lines that are observed on the graph, those would be the projections based on no changes in dementia incidence. But in the dashed lines, we see that there may be a decrease in dementia incidence in the future based on these projections of the decrease in dementia incidence. And it provides hope that there is something within this data that's suggesting that there are preventative strategies, especially considering that we haven't had disease-modifying therapies or treatment strategies yet. So I want to walk through what we understand about the pathogenesis of Alzheimer's disease and how we've leveraged that knowledge to demonstrate some efficacy to modify cognitive decline in randomized controlled trials. And then in the spirit of this webinar, talk about how that could be used in a prevention framework and what trials are currently ongoing that will test some of these hypotheses that Alzheimer's disease may be preventable. So we talked already about the accumulation of amyloid beta plaques within the brain. That is thought to be the first initiating event of these pathological processes that are associated with Alzheimer's disease. And I think an important thing I want to impart on you all is there are these pathologies that are associated with diseases. But as an example here, I have microglial cells, the brain's resident immune cells, surrounding plaques. They respond to these pathological insults. And this immune component of Alzheimer's disease seems to be critical to drive progression of the disease. And even in Alois Alzheimer's initial descriptions of Alzheimer's disease, he also described innate immune activation in seeing this gliosis within the brain. So there's this first accumulation of amyloid plaques. There's intense research trying to understand if there is a direct connection between the formation of these amyloid plaques and tau tangles. But with emerging evidence in humans with neuroimaging tools to track people longitudinally as they develop pathology, it does seem that there is a correlation of when amyloid accumulates in a region, and then when tau appears in concordance with that amyloid, that then subsequently leads to degeneration. So there may be an interaction there, but there are further studies that are needed to really validate those observations. And that's in the preclinical stage. These are events that are happening before the onset of cognitive decline. And what appears to be happening in this clinical stage of Alzheimer's disease, when neuronal loss, neurodegeneration is occurring in certain brain regions, is that there is both an innate and an adaptive immune response, possibly with T-cell infiltration, that is these cells are coming into the brain, and they may be playing a role in the processes that ultimately lead to neuronal loss and subsequent cognitive decline in individuals. And from longitudinal cohort studies looking at individuals with biomarkers, it's now appreciated that this is actually a long process. So there's this definition of cognitive impairment and clinical Alzheimer's disease, in which there's a clinical dementia rating signifying cognitive impairment. And then there's this progressive loss of neurons, atrophy, cognitive decline. And there's already substantial pathology, amyloid plaques, tau tangles, and neuroinflammation in the brain. But in looking at autosomal dominant forms of Alzheimer's disease and other longitudinal cohort studies, these processes begin years, possibly even decades, before there's any manifestation of clinical symptoms. And I think this is an important thing to think about with the current results I'm going to show from randomized controlled trials that demonstrate slowing of cognitive decline. These have occurred in individuals with early Alzheimer's disease, so that score of CDR of 0.5 or 1, where there's already many things that have happened in the brain related to Alzheimer's disease pathology. And there's already significant neuronal loss and cognitive symptoms. So this may be an explanation of why we have not yet seen full modification or slowing or stopping of cognitive decline in individuals with early Alzheimer's disease with various different types of interventions. So in thinking about that cascade, where amyloid deposition may start decades before an individual experiences cognitive decline, combined with the discoveries over 30 years ago that mutations in the protein that cause the generation of amyloid beta that leads to subsequent polymerization of this molecule and plaque formation, which these mutations in individuals that get early onset autosomal dominant Alzheimer's disease lead to overproduction of the amyloid beta peptide and longer forms of the amyloid beta peptide that are more prone to aggregate into amyloid plaques. The thought is then, why don't we target this pathobiology or test the idea of the amyloid cascade hypothesis, that if you can remove amyloid plaques from an individual, that will halt the progression of Alzheimer's disease. And that's been done with many anti-amyloid agents. In particular, the most successful to date have been monoclonal antibodies that clear amyloid plaques from the brain by directly binding and targeting these plaques. But there have been different forms of amyloid beta that have been targeted in large-scale clinical trials over the years. And a pattern seems to emerge from these trials, where trials of solanezumab, for example, that targets that earliest stage of soluble monomeric A beta, or oligomers with crenezumab and gantenerumab. We see, if you look in those trials and look at the presence of amyloid plaques in the brains of individuals once the trial is complete, individuals in those earlier trials did not experience the ability to become amyloid negative after treatment. But what has emerged with anti-amyloid agents that target insoluble amyloid fibrils or protofibrils, in the case of lecanemab, later along this cascade, suggested that there's clearance of amyloid plaques from the brains of these individuals as determined by a neuroimaging PET ligand, and that when there have been demonstrations of cognitive benefit in these individuals compared to placebo, that is correlated with an increased number of individuals that have successfully had plaque cleared from their brains during these trials. And again, I want to highlight that these are early individuals that have early AD. So they have cognitive symptoms, and there's substantial pathology that is already there within the individual's brains. So here's an example of that data with lecanemab in the Clarity AD trial of successful plaque removal after 18 months, where many individuals are amyloid negative at the end of the study. But the output of that was a slowing of cognitive decline of about 25%. And again, thinking about the idea of there's already been significant neuronal loss in these populations, and amyloid accumulation and tau accumulation has already occurred for many years before these interventions have taken place. But what was encouraging was a similar result was also seen with donanemab, where there was rapid clearance of amyloid plaques over the course of about 6 months, and similar demonstrations of slowed cognitive decline. Again, it wasn't halting disease progression or reversing any symptoms, but it was a slowing of cognitive decline, suggesting that engagement and removal of amyloid plaques from the brains of individuals can potentially modify the dementia symptoms associated with Alzheimer's disease. But there are still clear caveats associated with these anti-amyloid trials, in that there have been safety concerns with these agents in the disease population that's been tested, again, early Alzheimer's disease. These amyloid-related imaging abnormalities, ARIA is the term that's been used, and these safety concerns may be directly related to the mechanism of action of these anti-amyloid treatments, as there is a higher incidence of these events in anti-amyloid agents that effectively clear plaques when you compare the events of ARIA compared to placebo, even though some of these occur spontaneously. And most of these are asymptomatic cases of ARIA. They don't have any manifestation, but there have been deaths associated with ARIA as well when looking at autopsy. And these deaths have also been associated with anticoagulant treatments and TPA for stroke in some of these cases where individuals experience death after anti-amyloid treatments. And when we think about what is actually the cause of these deaths, these safety concerns, what are the consequences, is the thought is that this may be due to the fact of where amyloid beta is also accumulating in an aged individual, not just in the gray matter where neuronal cell bodies are sitting within the cortex, but this is the brain of a 67-year-old individual, and where you see significant amyloid plaque deposits in the brain parenchyma in the gray matter, highlighted by this box 1 in the image. What you also see is the accumulation of amyloid beta in the vessels of the brain as well. And when we look at these events of amyloid-related imaging abnormalities, when looking at what this looks like with neuroimaging techniques, whether it be RAE, vasogenic edema, or sulcal effusion, swelling within the brain, or RAH, microhemorrhage and superficial siderosis. These look a lot like what is observed in spontaneous cerebral amyloid angiopathy related inflammation. So when individuals have CAA accumulating in their vessels, there can be this inflammatory reaction in the brain that looks like this swelling or this accumulation of bleeding into the brain. And what's interesting in these spontaneous cases of CAA is these individuals are then positive for amyloid beta antibodies, endogenous antibodies, suggesting that there's this maladaptive immune response towards this pathology that's accumulating in blood vessels. And again, this these concerns prompt this idea that in these agents that have been tested in individuals with early Alzheimer's disease, even though we say early Alzheimer's disease in terms of cognitive impairment, a lot of damage and pathology already exists in the brain. So in addition to amyloid fibrils and tau plaques, there can be aggregation of other proteins within neurons. There can be a cerebrovascular impairment, not just the CAA accumulation, but small vessel disease that can independently lead to cognitive impairment or may synergistically combine with this Alzheimer's disease related milieu in the brain, where many of these other factors, even though there's an enrichment of amyloid plaques leading to tau tangle accumulation and neurodegeneration, these other factors may also be contributing to these cascades that are leading to cognitive impairment and decline. And when an individual is being treated, if, say, significant cerebrovascular pathology is accumulating, and you take an anti-amyloid agent and try to clear out plaques from the brain, this may explain why there can be these ARIA-related events that are a safety concern in these populations in aged individuals. So that creates this current challenge in the clinic of how to administer these anti-amyloid therapies. So in looking at the label for things like lecanemab, these clinical trials were with patients with mild cognitive symptoms, so mild cognitive symptoms need to be present, and then confirmation with biomarkers of amyloid pathology and with appropriate screening measures, and that there needs to be all of this confirmed and diagnosed before treatment would be initiated. And then this safety problem of ARIA is also linked to the greatest genetic risk factor for late onset Alzheimer's disease. One's ApoE genotype and carrying the E4 allele confers a greater risk of Alzheimer's disease in certain populations, but also increases the risk for these ARIA-related events. So needing to understand one's ApoE genotype is important for screening. And then just thinking practically of dosing and monitoring of these therapeutic agents. These are administered IV right now, every 2 to 4 weeks, combined with monitoring for the safety profile. So these are demanding regimens for patients and their families. So there's this possible challenge of how do we effectively administer these agents to people with differentiating circumstances that can't get them into these clinics that have all of these capabilities. But I think there still is promise, certainly, in the use of these anti-amyloid therapies if we think about other fields of medicine and how they've moved towards possible more preventative framework. So for example, in thinking about cardiovascular disease and seeing the similarities of plaque accumulation in a place that we don't want it, in this case, a blood vessel, and high cholesterol being a risk factor for that. So low density lipoproteins, helping contribute to the formation of these atherosclerotic plaques that are then building up in the vessels, leading to a cardiovascular event eventually. And what is also appreciated in thinking about relationships with Alzheimer's disease is this role that inflammation also seems to play in this process. So whether it be the low density lipoprotein particles itself or the activation of molecules such as PCSK9, creating this pro-inflammatory milieu that results in rapid more progression and buildup of these plaques in this pro-inflammatory environment. And similarly, in thinking about a target that has been used for prevention of cardiovascular events, we think about cholesterol lowering, and whether that be with statins or with PCSK9 inhibitors, there's been a relationship where it seems that treatment and lowering of LDL cholesterol will help reduce cardiovascular events. And I think from many of the large scale trials with statins, I think what's been observed and also appreciated is that it appears that the largest increase of reducing the risk of these cardiovascular events has come with an earlier intervention in these large scale clinical trials versus when someone may have already had stable coronary artery disease or a cardiovascular event already in thinking about its prevention, but it's still effective there. So similarly, then in hopes of thinking about where we may go in the Alzheimer's disease field is to have many of these randomized controlled trials testing this strategy of lowering cholesterol and seeing reduced risk of this disease. And we see from the combination of many of these large scale trials that correlation seems to exist where therapeutic lowering of LDL leads to a reduction in major vascular events. That's established by these large scale randomized controlled trials. But then in thinking about these pharmacological interventions, if you're first coming to a clinician when there's this clear establishment of this biology and this biomarker with the disease, the first recommendation may not be to use some sort of pharmacological agent, but rather to think about non-pharmacological interventions to reduce this risk factor that then leads to the disease. So the hope is that within Alzheimer's disease, we are moving in the next coming years to thinking about a similar framework of preventing the onset of cognitive decline with therapeutic agents or interventions versus treating at the symptomatic stage. And I think anti-amyloid agents are a way to directly test this when we know that these events are happening much earlier before the onset of cognitive decline. So really testing that amyloid cascade hypothesis. And this is currently being done. So recent study looking at solanezumab targeting amyloid monomers in preclinical Alzheimer's disease defined by biomarkers. But in this trial, they're actually similar to symptomatic Alzheimer's disease. There wasn't clearance of amyloid plaques. So there wasn't a slowing of cognitive decline compared to placebo. But we have these therapeutic agents, in this case, lecanemab, that clearly demonstrates efficacy in clearing amyloid plaques in individuals. And now there are trials, the AHEAD 3-4-5 study, prominent among them, where we're trying to identify individuals that are positive for Alzheimer's disease-related biomarkers and see if therapeutic interventions at those stage, in terms of secondary prevention, would then prevent the onset of cognitive decline in early Alzheimer's disease. And a similar trial is being done with donanemab. So in thinking about that framework in cardiovascular disease, so high cholesterol, reading out that biomarker, that would be hopefully the same strategy that would be employed to identify individuals that would be good candidates for testing this hypothesis directly. And there are, neuroimaging tools, so PET tracers to look at the presence of amyloid plaques or tau tangles within the brain of individuals. But again, bringing up that consideration of how could this be implemented at a larger scale if there was efficacy demonstrated, where something like a PET scan is certainly not trivial for people that may be at risk for disease to receive access to. So one thing that's been particularly exciting in the past years has been the demonstration of fluid-based biomarkers that seem to strongly demonstrate when there's positivity of these pathologies in the brains of individuals. So within the cerebrospinal fluid, various markers of amyloid beta, but also phosphorylated forms of tau protein actually strongly track with the presence of neuritic plaques within the brains of individuals. And these are the movement of those biomarkers as they relate to the accumulation of amyloid within the brain of individuals. And there are also the ability to look at markers of neuroinflammation for example, of astrocyte activation, glial activation within the brain with markers like GFAP, looking for tau accumulation in these individuals to try to especially identify that inflection point where there may be tau accumulation already in an individual that may signal that they may be especially at risk for possible cognitive decline in the coming years. And then markers of neuronal loss and degeneration. Again, in these examples identified in cerebrospinal fluid. But again, it keeps coming back to this consideration of how is this going to be accessible for people? Lumbar punctures, specialty clinics, neurologists to be able to take samples for analysis with cerebrospinal fluid via lumbar puncture. But what's been really exciting is seeing similar data being generated in blood samples from individuals. So looking at these analytes in plasma seems to also strongly have the ability to discriminate and detect these pathologies in the brains of individuals. So moving towards a test that may be more accessible for people in the future. And so the hopes with something like that's going to be tested with an anti-amyloid agent, if there's demonstrated efficacy, that we could move to thinking about all of these different factors that could be contributing to that pathology in an individual based on their genetic, their environmental exposures that could then lead to maybe it's an anti-amyloid prescription or other sorts of interventions that may prevent the accumulation of this pathology from ever happening, which we then would hypothesize would prevent this cascade that leads to cognitive decline in individuals. But I want to take an example of how personalized approaches and thinking about genetic risk factors, for example, may not be a one-size-fits-all strategy. There does need to be this personalized approach because it talked about the greatest risk factor for Alzheimer's disease that's been predominantly studied in high-income countries, mostly of European and in this case, Japanese descent. There's this increased risk for Alzheimer's disease based on carrying a copy of the ApoE4 allele, whereas E2 may be protective from getting Alzheimer's disease. But in looking at other cohorts, this may not be the case. The general thought is that ApoE4 and ApoE2 may impact, for example, the accumulation of amyloid, where individuals with 2 copies of the ApoE4 allele may be getting earlier onset of amyloid deposition, which is then accelerating the pathogenic cascade compared to carrying the copies of the most common ApoE allele, E3, E3. But those individuals also will get Alzheimer's disease, but there's this reduced risk with carrying a copy of the ApoE2 allele that seems to possibly be due to the fact that E2 carriers may have less amyloid deposition as they're aging. But this effect in looking at other is not quite as large. So in terms of thinking about possible personalized approaches and different communities that need to be served to prevent dementia, understanding something like a genetic risk factor may be important for certain people, but maybe environmental exposures or socioeconomic determinants of health may be another more impactful driver in other areas. And this then moving into the idea of modifiable risk factors for dementia without pharmacological intervention is something that I also find exciting. In this publication that's come out over the last few years from leading experts around the world, they've performed these systematic or identified systematic reviews, meta-analyses, performed their own analysis, and looked at risk factors that may be contributing to dementia. And in early life, factors like education, in midlife, we talk about high LDL cholesterol, hearing loss, traumatic brain injury, physical inactivity. These other factors at various stages of life seem to significantly contribute to dementia incidence. But what's exciting in thinking about those factors is if you combine those all up and think about a roadmap of the factors that could influence the risk of an individual getting dementia later in life. This combined analysis suggests that possibly up to 45% of dementia cases may be modifiable by addressing these factors. And what the group proposes is, in thinking about these risk factors, this will lead to possible decreases in vascular damage that contribute to dementia, possibly to reducing dementia pathology, like I talked about before, with amyloid accumulation or tau accumulation, depending on an individual's aging process, but also reducing stress in that inflammatory component, or even in the presence of pathologies, maybe some of these modifiable factors are building this idea of a cognitive or brain reserve, that the brain is more able to withstand these insults by addressing some of these factors that are promoting healthy aging and good health. So that could be, again, like that building cognitive and brain reserve, that could be in the presence of these pathologies, or if we think about specifically Alzheimer's disease, reducing exposures to these risk factors may then prevent this pathological cascade. So I talked about pharmacological agents, but there are, in randomized controlled trials, but there already are clear recommendations from this Commission on Dementia, ensuring good quality of education, hearing aids accessible for people, treating depression, thinking about traumatic brain injury and interventions, encouraging exercise, reducing cigarette smoking, prevent or reduce hypertension, treating of cholesterol, handling obesity, alcohol consumption, social engagement, screening for vision loss, reducing exposure to air pollution. These are all policy-based interventions that could be based, or individual choices that people are making to possibly reduce their dementia risk. And I think what is still also important, though, is to generate the data that these things will indeed be effective in thinking about randomized controlled trials, which is occurring already. So thinking about the finger trial a couple of years ago, that was one of the first to demonstrate these interventions of diet, exercise, cognitive training, multimodal interventions that would possibly lead to decreased incidence of dementia, was an exciting observation. And this type of intervention is being tested as a kind of preventative measure to not have that onset of Alzheimer's disease and dementia around the world. But then there are even early studies from small trials that even at that symptomatic stage, where significant pathology is already present in individuals and they have cognitive decline, that these intensive lifestyle interventions by things like diet, exercise, training may also help to slow the progression of disease. So it'll be exciting to see more of this data come out that directly shows how tackling the possibility of dementia onset with these multimodal interventions could lead to better outcomes for individuals. So that is where I want to conclude and have final takeaways within all that talk. I think what I would want you to take away from this is that, you know, our understanding of the pathological staging of diseases and the ability to develop technologies to track those in individuals, and combined with the development of therapies that have shown changes in cognitive decline, improvements in cognitive decline compared to placebo, are important first steps for the field. But in the coming years, looking at future randomized controlled trials and thinking about preventative measures of anti-amyloid agents in this preclinical setting will provide important insights into regulation of amyloid plaque deposition as a preventative strategy. So really testing that amyloid cascade hypothesis that has been predominant in the field for so long. And I think what is emerging from these epidemiological studies and lifestyle multimodal interventions is that thinking about what is good for the body is good for the brain. So in thinking about healthy aging and how that will be an important component to lower and prevent dementia incidence. So with that, I will conclude my presentation and hand it back over to Valerie.
Thank you, Dr. Self. What an amazing presentation. So before we transition into the Q&A session, as a reminder to our attendees, please continue to submit your questions into the Q&A pod directed to all panelists. And once again, this webinar will be recorded and available on ODP's website and YouTube channel. As you continue to think about your questions and enter them into the chat, we do have a couple of ODP announcements to share. I first like to point your attention to our save the date for our next Prevention in Focus webinar, which will be on Monday, November 18th at 12 p.m. Eastern. The topic will be on evidence for policies and practices to address global food insecurities. And then we have a Mind the Gap webinar series presentation coming up, actually next Friday, with Dr. Malawa from Duke University School of Nursing, titled Evaluating Synergies in Multi-Level Interventions, Mental Health in Schools as an Exemplar. Next slide, please. We are also pleased to announce that our 2025 call for early stage investigator lecture nominations are now open. The deadline is quickly approaching on October the 25th. So visit our website for more details, as well as to see our past awardees and view their recorded lectures. Next slide. And our last announcement, but certainly not least, in partnership with the CDC, we have launched our Quit and Thrive Menthol Challenge, which focuses on community-derived solutions to reduce menthol cigarette smoking among groups with disproportionately high rates of menthol cigarette use. So organizations are invited to submit entries illustrating what has worked for their communities, and submissions are opening on November 1st through February 28th, 2025. I will now turn it back over to Dr. Saliv, who will moderate our Q&A segment.
Thanks, Valerie. We have a number of questions in a short amount of time, but please keep entering questions into the Q&A box, and I'll try to get through them. An early question came about kind of the accumulation of amyloid plaques, Dr. Self, and does that accumulation, imply that why people who are younger don't get Alzheimer's? And I guess as a follow-up to that, what's the window, I guess, for prevention? Because you were talking about, preclinical, but
Yeah.
There's got to be some window for that.
Right. Yes. So a couple comments to that in terms of age. There are cases of early onset Alzheimer's disease, but predominantly aging is the greatest risk factor with a non-genetic cause, and that's late onset Alzheimer's disease, typically over the age of 65. But it will highlight in those individuals that carry mutations either in the amyloid precursor protein or presenilins, that are that molecular Pac-Man that basically results in amyloid beta generation, leading to overproduction of amyloid beta. Those individuals get Alzheimer's disease at a much early age. And they have the overproduction, and they have significant plaque accumulation that looks like an older individual at a much earlier age. So that supports the possibility that amyloid plaque accumulation is key for these events that lead to Alzheimer's disease. And also thinking about individuals with Down syndrome. So amyloid precursor protein sits on chromosome 21, which has 3 copies in those individuals with Down syndrome. And if you get to about 50 years old in an individual with Down syndrome, you'll see a significant amyloid plaque accumulation and cognitive impairment that looks very similar to Alzheimer's disease. So I think those genetics definitely show that there may be this, when amyloid accumulates, is a key event that's leading to this pathogenic cascade, possibly. And I think these are populations that are also being assessed in thinking about primary and secondary prevention and treatment. So I think in terms of thinking about our biomarkers, that's a great question. If an individual is amyloid positive, so we can see plaques clearly in their brain, that is on the road possibly to disease, but you probably need that positive detection to test that therapeutic intervention, say in just an aged individual that doesn't have an autosomal dominant form of the disease. But in possibly thinking about primary prevention, maybe these cohorts of people that have autosomal dominant Alzheimer's disease, you can think about primary prevention, because we know that these individuals will develop disease. Like, these mutations are 100% penetrant, and you can almost predict the age of onset based on the family history of these individuals that carry these mutations. So I think this is something that's exciting in thinking about, the AHEAD 3-4-5 study. The one that I mentioned is the inclusion criteria. You have 4-5, which is significant amyloid accumulation, and that's probably closer to the possible events that will lead to cognitive decline. But then the A3 study in that 3-4-5 framework is looking at individuals with less amyloid accumulation. And I think, using those different timings, I think is going to be critical for understanding, in terms of prevention by a therapeutic intervention or some sort of lifestyle intervention. Say A3 shows efficacy. And so then can we think about, interventions that would lead to an individual becoming amyloid negative if we used markers to detect that pathology in the brain? And that could be a possible management strategy. But I think it's going to be important to see that data and develop and establish that relationship of lowering plaques, timing of when those events happen, and then also combined with hopefully reduced safety risk, because there wouldn't then be those comorbidities associated with an aged brain.
Thanks. Yeah, I think that's a good point, that, preventive strategy has to be pretty safe to do it in people who are at risk, but not necessarily proven that they will develop a disease. So there's a question about, I guess, relating to that as well. So you said what's good for the body is good for the brain. And a lot of those strategies are recommended, to prevent other diseases already. How can we be sure that this Alzheimer's disease is a specific disease and not just some kind of, I guess the question is about, is it just a age-related degeneration?
Yeah, I think one, and that's a question. And I think one of the things that's really exciting in thinking about the biomarker space, or the concept of aging in general, is maybe to address that question as individuals are thinking more about biological age versus chronological age. So as we develop more of these tools to understand what sort of pathologies are accumulating in different organs, it could be the brain, it could be other areas, how much is that contributing to maybe what someone's true biological age is, like you said, and then is it just age-related degeneration? Is it a matter of like never hitting that benchmark, or can that be reversible, or is it simply just slowing the aging process that is not, reversing aging? We haven't really been able to demonstrate that, and I doubt we will. So I think that is what I would think about that. But again, in thinking about, it could be a natural progression of human aging, that eventually there will be too much of pathologies that build up in the brain when there are so many non-dividing cells that have a limited amount of time to exist. But how those different factors could accelerate that endpoint, we still don't yet know clearly. And I think that's a critical thing to think about in terms of these socioeconomic determinants of health, and really understanding, is it this unified mechanism of we're going to get there, and we're just accelerating it because of certain exposures? And like I said, with this possible increased incidence of dementia in these higher income countries, is that if it is this aging disease that we have, let's create these systems and infrastructure in place so that can happen as slowly as possible. for people, and that they may die by other causes that aren't related to this chronic neurodegenerative condition that, saps people's cognitive abilities and ability to function normally. So minimizing the disease span and maximizing health span.
Great. Well, this, I think, is our last question. It's about amyloid deposited in other parts of the body besides the brain, and what kind of clues or signs and symptoms are related to that could help with this search for treatments or prevention.
Yeah, I think there's actually growing appreciation of some comorbidities that are associated with other amyloids that are accumulating peripherally. For example, I'm thinking about what's been shown in the pancreas, an accumulation of amylin, and then also, I guess, accumulation in blood vessels as well, of not just plaques, but also amyloid. But I think in many of these different cases, I think what could be appreciated is that there's this biology that's happening, and these things are existing physically in space, and our bodies are also created so that things can flow and move effectively. And I think a common mechanism of what we're seeing is when there are obstructions in different places of the body, that's not good for the whole system. So I think in terms of that sort of preventative strategy of maintenance of these systems, I think that might be what I would think about.
Thanks so much. I think Valerie has some final words.
Thank you. Thank you again. That was an amazing presentation, Dr. Self. I see there are still tons of questions in the chat, so hopefully you will still be able to answer a few of those for us at another time. Thank you also, Dr. Salif, for the wonderful introduction, for leading this very engaging Q&A discussion. Also, thank you to my ODP colleagues, Catherine, Melissa, Teresa, Winnie, Lisa, and James that worked together to make this webinar possible and to run smoothly behind the scenes. And once again, an additional thanks to all of you for making time to join us today. All of the questions were so thoughtful, comments and resources shared. And if you have any questions about the webinar series or today's presentation, please feel free to continue to email us at preventionandfocus@nih.gov. We hope to see you at the next one on November the 18th. Thank you again for attending.